Febrile neutropenia, another little controversy about it. First of all, confirm me, are these 4 options are same? Is there any change? I mean, in the sense of the wording, that's all. Right. Now the question is, if you look at WBC, colony stimulating factors, the most recent recommendation of the International Society is on oncological and infectious diseases, it is against the routine use of CSF, colony stimulating factors, for uncomplicated cases of febrile neutropenia. But examiner didn't ask like that. He didn't specifically ask you whether do you use it regularly or is it against about it, nothing was asked, it is a plain MCQ. So I think 2 possible answers for this question. Antibiotic prophylaxis, granulocyte infusions, they both are well accepted. Between hand washing and colony stimulating factor, probably somewhere answer is lying. Okay, let me not be dogmatic to say A is only the answer, no heartbreak about it, let us wait for the results to come. Now progressive multifocal leukoencephalopathy is a typical, one question on apps, you all agree with me? Infliximab, then cetuximab, bevacizumab, nutalizumab, oh there is a big list, every time we used to discuss that, right? So it is the natalizumab which is the one which is associated with the development of a progressive multifocal leukoencephalopathy is what need to be remembered. In zinc deficiency there is no gastritis, was it there in the options? Okay, I think this is another simplest question. Now bone marrow transplantation is done for the Wiskott-Aldrich, severe combined immunodeficiency. What was the 4th option? Can you recall? Huh? Aplastic anemia, we do that. So the ataxia telangiectasia, we don't do that, is what you should be very sure. With regard to leptospirosis, we give IV crystalline penicillin. Huh? What was there? Leptospirosis with multisystem involvement is called as what? W for Weil's disease. Every leptospira does not lead to Weil's. The moment there is a multi-organ failure, it's called as Weil's disease. Okay? Now, in the Weil's disease, my question to you is, when will antibodies will rise? When will antibodies will rise? First of all, what is the differential diagnosis for the Weil's disease? Complicated malaria, because that will also cause jaundice like Weil's, that will also cause hepatorenal failure like Weil's. It's a very common differential. I still remember a patient admitted with ARDS with jaundice with hepatorenal failure. Our suspicion was that he is a case of leptospirosis. Okay? We did dialysis, we gave supportive care, everything. In spite of our wonderful effort, patient died. So just that happened somewhere after about 1.5 weeks. We don't let patients die that easily. Now what we will do? We'll put him on ventilator. We do all efforts to see that he sells the last penny of his property before dying. So now the question is, just before we were about to dispatch, we just took one sample and sent, because our suspicion about leptospira did not die, and that sample turned out to be positive. So the first week sample negative, but the second week sample positive. So the reason is the antibodies. I still remember presenting a mortality conference on a leptospira patient. So the antibodies does not reach a detectable level until the second week of illness. So that becomes the answer. 5 to 10% is a proven mortality rate in Weil's disease. That's all. Now let's go to the, how many answered it as penicillin? Oh, you require coaching. We'll give free coaching, don't worry. Because IV crystalline penicillin. I mean, unfortunately we will be knowing few things while we are treating only. My first case of leptospira I didn't see in housemanship, honestly. I said, अरे penicillin इतना outdated drug है, इसको इस्तेमाल करेंगे क्या? Ceftriaxone and penicillin are the only wonderful drugs against leptospira. So any day. So that's the thing. Next, let's go to the next question. Atrialization of right ventricle because of a low placed tricuspid valve is basically Epstein's anomaly. Plasmid transferred from one bacteria to the another is called as conjugation, transduction, transformation, grift. Everything is a favorite topic of the examiner. Staphyloma, the most common cause is perforated corneal ulcer on any given day. Out of all is the tropicamide. How many answered it as cyclopentolate? Good guess, that went wrong. I'll tell you, if you look at atropine, it will take at least 2 weeks for it to persist, and it will take a long time. Hometropine also will take little long, but cyclopentolate will induce cyclopentolate within 30 to 45 minutes. Whereas tropicamide will have an onset of action between 15 to 30 minutes. So that makes tropicamide the most fast acting cycloplegic is what need to be remembered. Rotavirus is very common cause of the infantile diarrhea. Erythema infectiosum, different first day, second day fever, everything, rash, you should be sure. So it is caused by parvovirus B19. Carcinoma lower third of esophagus any day is Barrett's and adenocarcinoma. This also everybody will answer correctly. Mast cell, yeah, one question comes on staining. That is our agreement, right? Pneumocystis stain, methenamine silver stain, so many stains. So it is a toluidine blue which is used for staining the mast cell. So sarcomas generally go by hematogenously. What is a traditional question of examiner? All sarcomas are hematogenous except what is what he used to ask. He knows that you are doing old questions very frequently. So this time he asked, what out of the exceptions which go lymphatically, which is the only one which goes hematogenously. So that is the paradox about it. So clear cell carcinoma, sarcoma, epithelioid sarcoma, angiosarcoma and rhabdomyosarcoma, they are all known to go exceptionally to lymphatics, is what you should basically remember. Beerbeck's is what you find in Langerhans cell histiocytosis, which is another common topic. I mean, these are all the topics common in AIMS All India question bank, not our AP, but we borrowed these questions this time. Nephrotoxicity is a side effect of cisplatin, which you should be 200% sure. Increased milk secretion is seen with metoclopramide or any dopamine antagonist, but dopamine, what does it do? Suppresses. So bromocriptine like drug or cabergoline is used in prolactinomas to suppress prolactin, not stimulate. Paracetamol antidote would be N-acetylcysteine. HRCT can detect even a minimal bronchiectasis. The most common cause for the esophageal rupture is the instrumentation, that is the rigid esophagoscopy that we introduced. This is a good question. What are the various structures that lead to anatomical constrictions of the esophagus? Diaphragm is one location. So you have got upper, middle and lower constriction. 14 to 16 centimeter from the incisor tooth is upper constriction. It is located behind cricoid cartilage. Middle constriction is thoracic constriction, and that is a place where aortic arch is located. And lower constriction is phrenic constriction. So that is the reason bronchus may not lead to, does it? Aberrant left subclavian artery is very well known to lead to development of actually there is no aberrance given in that option, but bronchus is not documented, is it? If so, at what level? I mean, I like to know from the literature. It's as enigmatic for me as much as to you. Selenium is a constituent of the glutathione peroxidase. With regard to the melanoma, which has the worst prognosis, which variety? Acral lentiginous melanoma has got the worst prognosis. Class 4 is Breslow, invasion of, what is class 4? Tumor extends between bundles of collagen of reticular dermis. Between papillary and reticular is level 3. So invasion of papillary dermis means But even 4 also has already invaded papillary, gone up to reticular, na? Is it? So what is your potential answer? You mean B for boy, class 4. But I am showing you the classification of Clark, na? Clark told that between papillary reticular it is level 3 and reticular dermis, if it is extended it become level 4. Papillary के नीचे reticular है, अगर reticular गए तो papillary already invaded, ना? Huh? Okay, we will debate about it, no problem. Okay, I mean predominantly nodular has got a worst prognosis was the option A, है ना? I mean we will take up because we need to see the end of 200, huh? Definitely we will come back. Focal nodule is very common between anterior 1/3 and the posterior 2/3 ka junction. Now what is the last part? It is a journey to Tirupati. Most unexpected questions which are equally bad to everybody. So pray the God that all your classmates definitely would have done them wrong. You are the only great guesser. What is canal of Petit? Have you heard of that? If you type canal of Petit in google.com, you don't get anatomy questions. You will get one canal of Petit which is a actual water canal. So I thought the GK questions are also there like UPSC paper. So it is the space between the anterior and posterior suspensory ligaments of the lens of the eye where the canal of Petit is typically located is what need to be remembered. Which is not a compartment of leg. How many checked your leg? I know. So basically it is divided into anterior, lateral, deep posterior and superficial posterior. There is no medial. Medial is all tibia which is subcutaneous, hai na? That's right. Maybe if you are seriously reading in reading room for another 6 months you may develop a medial compartment also in the leg. Now for the basal metabolic rate what is important? I didn't understand the frame of the question actually. What is the most important thing that consumes energy for maintaining BMR? Was it the idea? I think my guess would be a sodium potassium pump. I don't know what was the thing in your mind. Liberman Bowkert is an Englishman who left independence to us, but we are still struggling in slavery of remembering the eponyms, right?